Hello, everyone. Welcome. As Jerry said, we're glad you found your way here. So just pay attention during the next few weeks to the emails we send so that you can sort out where you need to be. Is this working?
Yes.
Oh.
I'm just going to push you right here because you're...
Oh, I was leaning on...
the slide.
Okay. Sorry, I was leaning on something. So, as Jerry said, the library is closed right now. It will be back open soon. And once all of this renovation and all of this construction is finished, it's going to be glorious. And we're all looking forward to it. So, let me just say this is a series presented by the Newport Beach Public Library Foundation. I'm Adrienne Windsor. I'm a board member. I have been on and off for many years. And it's also supported by UCI Irvine Health. And I want to especially acknowledge Kunga, our program director, and Jane Merritt back here. These two women do so much to make this program the success that it is, and to provide all of the logistics and the personnel and everything that it takes to put a program together. We would like to thank our generous sponsors, Mike and Polly Smith. As Jerry said, they have been with us from the very beginning, every year. They write a check to sponsor this program, and it's meant a tremendous amount to us because it means that we have a sense of continuity. Polly sends me an email and says, I'll send my check as soon as my taxes are done. And when it shows up, Sean in the office sends me an email and says, the check is here. So we really are grateful to them for their support all these years. A quick bit about us. The foundation is a membership-driven organization. How many of you are members? Well, I see some of you didn't raise your hands, so I want to encourage you to become a member. And you can go to our website and you can join. Our entry-level membership is only $50, but that puts you on our mailing list. You become a part of our community, and you begin to get all of the notices for all of our programs and for all of the activities that are taking place. And in addition to that, the foundation is the major marketing source for the library. So you also will learn about the things that are happening here at the library that you may want to attend. This is the time when we announce all of our programs for the year. Jerry alluded to Spotlight in Science. We even have a Nobel Prize winner coming this year to speak in the spring. Library Live will start in October. We have our first speaker, and the Woody series is going to open for individual ticket sales very soon. Kunga leads the book discussion group. We have a financial workshop. These are some of the many things that the foundation does. So when you become a member, you know that you're supporting the work that this foundation undertakes. So I urge you to do that. It's very important to us. So a few reminders. We will conclude the program with Q&A. I'll go around with the microphone so you can ask your questions. And we urge you to make your questions generic rather than too specific, because to your own situation, as Jerry said, these are videotaped. And if you ask questions relating to you, it's going to go on the video. So please just ask generic questions. And afterwards, our speaker will be up here in front and be willing to take questions from the audience for you. Also, please remember to silence your phones if you haven't done it already. I'll give you a second. So I am pleased to announce tonight's speaker, Dr. Hamid Djalilian, Dr. Hamid Djalilian. He has been here before, several years ago, and we are happy to have him back. He is the director of UCI Health, Otology, Neurotology, and skull-based surgery services, as well as the professor for the Department of Otolaryngology. And I want you to know that I went to Siri this afternoon and said, how do I pronounce this word? She gave me 3 links on YouTube. So I also asked Dr. Djalilian how long it took him to learn to pronounce it. He completed his fellowship in neurotology and skull-based surgery at the University of Minnesota Hospital and Clinics, and he has also been totally trained. I'm always amazed, these doctors who come to us, they spend years and years and years honing their skills so that they can be useful to the world, and it's such a gift to us. So tonight, Dr. Djalilian will be speaking to us on understanding hearing loss and the latest treatment options. How many of you have hearing aids? How many of you need hearing aids? All right, please join me in welcoming Dr. Djalilian.
Thank you so much for that very kind introduction, and thank you for taking the time to come. I know it's the evening. I have lots of better things to do than to come here, and I appreciate you finding your way here. It's actually pleasantly surprised to see so many people, because I thought there's no way people are going to figure out, because I went to the library and it said, it says closed. I said, so maybe I got to go home. But fortunately, I was able to find it. So, well, I'm going to talk about hearing. I'm going to talk about a couple other things because these are also common issues, dizziness and ringing in the ears being the others. So we'll talk about sort of everything. So, how does the ear work? Basically, sound is a movement of air molecules. So, as I'm speaking here, this goes into, the speaker system. The speaker system creates vibrations, and then that moves the air. These molecules are moving. They come into your ear. They vibrate the eardrum. These are very tiny movements. These are on the order of, in 10 to 100 nanometers of movement, which is, about, 1/10,000,000th of a yard, if you think about it. So it's a tiny, tiny amounts of movement. But that movement then gets a little bit amplified with these little hearing bones that are behind the eardrum. You see you don't see my cursor. I'm pointing there, and it's not showing anything. Well, and it's hard to point with this thing. Well, so number 2 is basically the... let me see, this should be a way for me to point. Give me 1 second. Okay, do you see this? All right, excellent. So this is the eardrum here at the end of the ear canal. Our auricle, the shape of our ear, and the shape of the ear canal actually increases the loudness of sound in certain pitches of sound. And then the hearing bones work with multiple different sort of mechanical actions that also amplify the sound a little further. And then the sound gets to the inner ear, which is that number 3. And the inner ear is filled with fluid. So you have to basically take air molecule vibration and translate it into fluid vibration. So it requires a little bit more force to do that. That's why the ear has to amplify the sound a little bit before it gets to the inner ear. And then inside the inner ear, there are these tiny, tiny little cells that pick up the vibration of sound, and that vibration is then translated into electrical signals that go to the nerve and eventually make it to the brain. The brain then puts all that information together and figures out what the word is. So it's a very complex process that occurs instantaneously when you think about sort of all the steps that need to occur for one to hear. It's amazing how quickly our brain can figure that out. Let's see here. There we go. Okay, so if you've had a hearing test before, basically what's done in a hearing test is we test the hearing in the frequencies of sound, the sort of the pitches of sound that are most important for speech. So we hear a much wider range of frequencies, but we primarily test this range between 250, which is like the middle C in the piano, and 8,000 hertz, which is if the piano had one more octave to the right, then that would be sort of, that would be 8,000 hertz. But if you think about all of the left side of the keyboard of the piano that we can hear, we don't really test because most people don't, when they speak, they don't speak at that low a pitch. So it's not very critical for the purpose of testing. So we don't test it. You could test much wider range, but most clinical devices don't test in those very low or very high. We have research devices in our lab that we can test people with those kinds of things, but not in a clinical device. And then what is marked is like the lowest sound, the quietest sound you can hear at every pitch. And then they test the hearing a couple of different ways. One is, of course, you test each side. And then we also test the hearing from behind the ear. So you can put the sound vibration through the bone behind the ear, and that will then directly go to the inner ear and bypass the ear canal and the eardrum and the little bones of the ear. So then that's done, and those numbers should all be the same. So this is sort of what common sounds are, just so you get an idea. So you're probably, with this speaker system here, you're probably hearing me at around, I would say, about 60 to 70 decibel level, which is kind of right around here. And most conversational speech is between 40 and 60. So if I wasn't using this and I would be sitting next to you and talking to you, then you would hear me around probably 50 to 60. If I were to whisper, in your ear, that's about a 20. So you kind of can get a general idea of what sort of loudness levels are. And of course, the lower you go down here, the more damage that sound can create. So the more exposure to very loud sounds you have, the more damage you'll accumulate over time, because we're born with the sort of a fixed number of cells in our inner ear that pick up that vibration, and extremely loud sound or loud sound for long durations of time will damage those cells. And once we lose them, they're sort of gone forever. Although I'll tell you a little bit about some of the research we're doing to try to regenerate those cells and whatnot. And sounds that are, like concerts and, airplanes taking off and gunshots are sounds that if you're not wearing protection, you will very likely get immediate damage from that type of sound. So a single gunshot is enough to potentially cause permanent damage, depending on how close it is to the individual and how much protection people are using. So for sounds that are in the sort of lower range, the very loud levels, then we recommend earplug use, all the time. And so I was actually just at a show last night at Segerstrom, and it was a wonderful show, but it was extremely loud. And I don't know if you went to this last one that was there, the Anne Juliet. I actually wore earplugs and I covered my ears because I was near the speaker, and it was very loud. And I was constantly watching my kids to make sure they don't take their earplugs out. But yeah, you have to, if you're going to a concert, definitely take earplugs with you, because you will most likely walk out with some hearing loss. And I'm talking about loud concerts. If you're going to an acoustic concert or symphony, it's probably you're not going to get damage from that. But if you're going to a big concert, you wear earplugs, please, and tell everyone who's with you to have earplugs. I was actually at a concert with my kids a couple of months ago, and for the first time I saw actually all the workers had earplugs, which was very pleasantly surprising for me. But I was telling them, hey, you gotta push it in if you want it to really work, because if earplugs are sticking out too much, they're not doing anything. You gotta actually push it all the way in. We're actually, as part of our academy, I've written guidelines that we're hoping that would become implemented for sports games and concerts venues, that there would be some requirements in terms of the loudness so that they're not excessively loud, because most people aren't wearing earplugs, and they're going to walk out with damage. And so the goal being is that they would have earplugs available for people. They would have instructions on how to use earplugs on like the tickets and that kind of stuff. And there would be quiet areas that people can escape to if they want to. All right, so when we're looking at a hearing test, this is a normal hearing test would be 20 and above, meaning that somebody could easily hear a whisper or the ruffling of the leaves from the wind or something. But as we lose hearing, we will lose more and more ability to hear some sounds without some level of amplification, like a hearing aid or something. And when we look at sort of where speech is, most of the vowels are in the low pitches, and most of the, no, I shouldn't say most, but some of the consonants are in the high pitches. Now, most people lose hearing in the high pitches first, because everybody gets age-related hearing loss, pretty much. There's some people who are, exceptionally genetically protected from sort of age-related hearing loss, but that's a very kind of uncommon thing. Essentially, everybody starts losing hearing in our actually late teenage, early 20s, but it's in the very high pitches that are not tested, so we don't actually see it on a test until it sort of comes into the range that's tested around between age 40 to 50 is when we will start seeing the loss of hearing in the highest pitch, this is our 8,000 number. And 8,000 is where the sounds of the F sound, the S sound, and the TH, the Th sounds are. And those are very high-pitched sounds. So if you have high-pitched hearing loss, you're going to have difficulty telling the difference between fat and sat, for example. Now, it's sort of the other end of the spectrum with young children. Actually, the most common birth defect is actually hearing loss. So the most common thing that can go wrong when a child is born is that they actually have hearing loss. And it's very costly to educate a child who has a significant hearing loss. And so nowadays, we basically try to identify children very young age and try to get them rehabilitated either with hearing aids or with what's called a cochlear implant. And cochlear implant is a device that can essentially replace the function of hearing for these children and directly stimulate the nerve. And so if a child is identified early enough and they get implanted early enough before, like ideally before the age of 1, then they have about a 90% chance they'll start school with normal hearing children. They will speak normally, but if they take the implant off, they're totally deaf. And this is actually the cochlear implant, basically, and the implant basically goes under the skin and extends, goes inside the inner ear, because when most people who have hearing loss, they lose just the hearing cells, the ones that pick up the vibrations. They don't lose the nerves. The nerves are actually there, and the nerves will stay for many, many years. Now, usually after about 20 years that you start losing the nerves and stuff too. But there is kind of a relatively small time window in children that you can implant them and they can actually catch up with normal hearing kids. And so by the age of 2, if the child hasn't gotten implanted, they're going to fall behind. And by the age of 9, if somebody hasn't had an implant, they will never be able to develop language anymore because the brain's kind of hardwired for language at that point. So one of the things that we do sort of in our areas, we also do a lot of research and also education. And one of the things that we've been trying to make people aware of is the damage that noise can create. Back, when I was in school, if you wanted to listen to music, you had the Walkman, and there was like a cassette tape, and you could listen to at the very most would be 1 hour of music. And then you have to take the tape out and flip it over, and so you got a little break there, and you could listen, and then you have to go and find another tape. Now you can listen to music all day long on your phone, and you have very high quality speakers that are now available in the AirPods and whatnot, that allow you to listen at a loud level without distortion, which, back with the Walkman, if you turn it too loud, it just didn't sound as good. But these digital music, of course, plus very high quality speakers that are now inexpensive relatively, has created this problem. So we do a lot of stuff for community education, so try to get some stories out to, in various sort of networks and newspapers and stuff about danger of noise-induced hearing loss. Of course, hearing loss is common as we age because of the fact that everybody loses hearing with age, and then all noise-related hearing loss accumulates over your lifetime. So that's why it's important that children are careful with their hearing, because any loud noise that they are exposed to will cause some damage, would then accumulate over time and then in adulthood, etc. So of course, tell your, children and grandchildren about this kind of stuff as well. But a lot of people who actually need hearing aids, who could benefit from hearing aids, don't get them because either the cost is high or they don't like the idea of wearing something, it requires the ability to go into an office multiple times to get them tuned and stuff, and so it's difficult, not available for everyone. But one thing that we have that's more recently, probably in the last 5 years, has been figured out is that there's a very strong relationship between hearing loss and dementia. And at least it's what is thought to be the case is that the more people have hearing loss, the less likely they interact with others, the less they socialize, or they go to a social environment, but they don't interact with people. And there's sort of that reduction in social activity causes a reduction in cognitive function over time. And recently there was a clinical trial that showed they actually tested to see if using hearing aids will help slow down the cognitive impairment, and it actually did. So, if somebody has a significant hearing loss, we strongly recommend hearing aids. Before we couldn't say definitively, but now based on this clinical trial that was conducted recently, we found that it really does benefit, and so we really would encourage people to use them. And we talked about sort of why, because a lot of people don't like the way they look. Everyone wants the small hearing aids that go inside, but unfortunately, most people need the sort of behind the ear ones. And the reason being is the devices that go in the ear canal primarily are useful for very small amounts of hearing loss that are across all pitches. But most people get hearing loss in just the high pitches, and their low pitch hearing is actually good. And so the smaller devices just don't work very well for those. Sort of a word about over-the-counter hearing aids. Over-the-counter hearing aids got approved just a couple of years ago, and that basically allows companies to directly sell to consumers. Now, most of the hearing aids that you will see advertised, and you probably are potentially bombarded by these ads online and in newspapers and print and whatnot, are for devices that are actually not very good at all, because most of those are very kind of relatively simple, what we call amplifiers. They have a sort of a set, couple of set programs for, like, let's say mild, medium, and maybe a little bit more significant. But they're not individually programmable for people. And because everyone's hearing loss is slightly different, everyone's ear is a little bit different in how they perceive sound and how they like to perceive sound. So it's more beneficial that sometimes people actually use the better devices. Because there's a tendency, sometimes people use the over-the-counter device and they're like, it makes everything too loud and I didn't like it, so I'm not going to use hearing aids because they don't help me. But if they just used a better device, they would actually been happy with it. Of course, they are lower cost, but part of that lower cost is because you don't have somebody you can go to if you have a problem with it, and they'll fix it for free, essentially. There are a couple of companies that allow where you send your hearing test into them, and then they will then send you the devices, and then they'll program it over like Wi-Fi, basically. But the reality is those devices end up costing very close to the cost of what actually one that you would get from an audiologist. And the reason, of course, hearing aids are expensive is really the fact that you have a person that you have to interact with. And I mean, the devices are expensive too, but but there is a lot of added cost because for several years you're essentially getting all sort of services for free. I'm going to shift gear a little bit, talk about tinnitus or ringing in the ear. So tinnitus is this perception of sound in the absence of sound. So it's like ringing or buzzing or humming or hissing, etc. It's a sound that's produced in the brain. It was thought to be the reason Van Gogh cut his ear off. However, I just went to the Van Gogh Museum about 2 months ago in Amsterdam, and that was not the reason he cut off his ear. It was, he had a very bad argument with his roommate, and he just went crazy and just cut off his ear. But anyways, that had nothing to do with ringing in the ear. But I have that picture here just for fun. It's a significant problem. There are a lot of people who have it. There are several million people actually in the United States who are disabled by it. It's so loud and bothersome to them they can't function. And it's the biggest cause of disability in the military and the sort of veteran population. So there are a couple $2 billion a year spent by the Department of Defense and the VA on compensating veterans for tinnitus. Right now, there's really no cure, but we're working on some, which I'll talk about a little bit at the end. Balance is another area that's sort of within the sort of realm of the ear. And balance is sort of a complex system because our balance uses our feet, the nerves in our feet that detect pressure on sort of our soles of our feet. And then our eyes will integrate information based on the three-dimensional or vision. And then the inner ears will tell the brain how the head is positioned. So basically we can tell which side is up even if our eyes are closed and we're underwater, for example. And that information all goes to the brain. The brain has to integrate that and then get people to control their balance. This slide just says exactly what it just said. Most forms of dizziness falls into three main categories. The one category is what we call sort of lightheadedness. And lightheadedness is basically due to a drop in the blood flow to the brain. This would be the most common example would be somebody says, I get up quickly and I feel off, or when I get out of bed, or when I stand up or sit up, that kind of thing, that will then suddenly make me feel dizzy for usually a few seconds up to maybe at most like 30 seconds. And then they sort of get equilibrated and they sort of go on. That usually is from things like low water intake and blood pressure medication most commonly, and just being what we call deconditioned, not exercising enough. Second is the vertigo. It's a room spinning sensation, which is primarily driven by the inner ear balance organ or the brain, which has to coordinate eye motion. And then the third is the balance. Most commonly, it's actually caused by the drop in the function in the nerves in the feet that can't detect your center of gravity. So your brain just doesn't know how much to move the muscles to be able to control. And there are some uncommon conditions in the brain that can cause significant imbalance, like Parkinson's and increase in the fluid pressure, etc. Now, I'm just going to tell you a little bit about our research, too, that we're doing to try to actually solve these problems. I generally, when people come to me with a problem, I'd say, do you have a solution for it? Because that's all I want to hear is there a solution to this problem or not? If not, then, find a solution. And that's the way I approach sort of medicine, is that if the only way to fix hearing is hearing aids and there's a better solution, then we want to find that better solution. So, what do we do? Why do we do research? We try to really understand how diseases occur, and then based on that try to develop new treatments, which would include devices or medications or new treatment protocols. And then, of course, to train sort of the next generation, so this work will continue, because I don't think we're going to be able to solve everything during my lifetime. So we're going to have other people who work this in the future. And one of the areas that we're working on now, and we're bringing on a full-time PhD scientist to work on this in our lab, is on hair cell regeneration. So hair cell are those cells in the inner ear that detect vibration. These are those little hairs. This picture is, now on this screen, it's probably about 1 million times larger than the actual, those actual things are in life. And what they do, they're sort of floating inside this little gelatinous material. And so when that wave of fluid comes through the inner ear, these little hairs, if you may, move, and then little molecules of potassium enter the cell, and then the cell detects that and then sends a signal to the nerve, and then that signal goes to the brain. And that's the reason is, people lose hearing is because we lose those cells. And those cells, we have, as I said, a certain number of them, you lose them, they're gone. So you have to, do everything you can to preserve them. Now, we're working on trying to regenerate them and on preserving them. This is another area of our work where we're actually working on the preservation of these cells. The cells, the reason most cells in the inner ear die are because there are these component cells called mitochondria. Mitochondria, they produce energy in the cells. They're these this orange thingy here. They produce energy, and they get rid of damaging molecules, what are called oxygen radical molecules. And these oxygen radical molecules will damage things, and so then mitochondria takes it in to sort of prevent damage to the entire cell, but in that process, it sort of sacrifices itself for the cell. And then with time and sort of as we age, we lose those, and then the cell doesn't have the energy capacity to produce energy, and then it dies. Now, we've been working on actually preserving those mitochondria. So that mitochondrial dysfunction is the primary reason for age-related and noise-induced hearing loss, which are the most common causes of hearing loss, of course. So we've actually been working on transplanting mitochondria, meaning that we get mitochondria out of healthy cells, which most commonly we use muscle. Muscle has a lot of mitochondria, and on other cells. And then we take those and have been working on getting those into the inner ear. We initially did it in a sort of cell culture, and now recently, for the first time sort of ever in the world, we were able to successfully get it into the inner ear hearing cells. So these are those inner ear hearing cells. These purple dots that you see inside, those are the new mitochondria that we injected and got into those hearing cells. So then we wondered, well, does this actually work? And we did an experiment where we had some mice that got the mitochondria and some mice that didn't. They just got like a saline injection in their inner ear, and then exposed them to noise. And we found the ones that got the mitochondria, they actually preserved their hearing, and the ones who didn't get the mitochondria lost hearing. So we're excited, and so we're doing more work to try to figure out what's sort of the sweet spot in terms of preserving hearing from noise. And then we're also looking at the effect of it on aging. And mice, their sort of lifespan is about 2 years. So basically in 2 years, they live what humans do in about 80 years. And tinnitus, of course, there are two aspects to tinnitus. One is the sound production, which is in the brain from the loss of hearing cells. And then there is another component of it, and that component of it is from the brain's attention to that signal. So the more attention the brain gives the tinnitus, the louder it's going to seem to the patient. And we've been working on addressing it from both the sound production side and then the attention side. And we've had some good success, and which I'll tell you about a little bit here. So we've been sort of doing a lot of research on using electric stimulation, because what we found is that the reason we get ringing is because we lose the hearing cells, those little vibratory cells, those ones with the hairs. But we don't lose the nerve cells. And if we can stimulate those nerve cells in the ear, we can actually make ringing go away completely. And we were able to successfully do that in about 60% of patients that we did experimentally. We've also developed some sound therapy system, both online and sort of as a device, that were all both developed at UCI. So this is actually one of those experiments that we did. This is, we placed an electrode through the ear canal, through the eardrum, behind the eardrum, and stimulated the inner ear. And we're able to, 60% of patients, we could make the ringing completely go away. And in some of them, we were just with 5 minutes of the stimulation, we could make the ringing go away for hours. So we got very excited, and so now we've been working on a device that would then get implanted behind the ear that can do that stimulation, and it can be sort of turned on and off by the patient. So this is actually this little square that you see is actually the electronic chip that would go behind the ear eventually, behind the eardrum. And then there would be a component in the ear that sort of helps charge up the device and provide the programming to it. And then there would be like a handheld device for like the audiologist and whatnot. Now, hearing aids, as I mentioned, a lot of people don't get hearing aids, but we have been working on trying to develop a new generation of hearing aids, because hearing aids, one of the issues with them is that people have is the fact that they don't sound very natural, because the hearing aids have kind of a limited range of frequencies that they can give you sound in. Because if you think about, like these high quality speakers, the higher the quality, the bigger they tend to be, because they provide a wider range, sort of low frequency, high frequency. We're trying to produce high quality sound out of this tiny little speaker that's inside the ear canal, and that just doesn't give us the range. And so most people with hearing aids, even if they use hearing aids a lot, they don't use them for music, for example, because the music just doesn't sound as good with a hearing aid. They sometimes will actually take their hearing aids out in, like, let's say, a symphony environment or something. Now, there are implantable hearing aids that are available where the stimulation is done by vibrating the hearing bones directly. There's this little magnet that's actually placed behind the eardrum, and then there's a device in the ear canal that sort of vibrates that magnet from the outside. So we thought, can we do this without the need for a surgery? And so we came up with this device that sits deep in the ear canal, like this, and it actually directly vibrates the eardrum. And that can produce like a very high quality of sound. We've tested it in about 30 people so far, and 30 people who had hearing aids, and then they used our device, and they said that the quality of sound was just leaps and bounds better. This is actually the first time we put it in somebody. This is my engineering partner with whom we've developed several devices. And so I'm putting the device in his ear, and then we're stimulating it sort of electrically through through here with speech and music. And then on the other side, we're giving him sort of conventional testing, so then we can actually match to figure out what level output the device is putting in there and whatnot. And then we did some further experiments with some grants that we got, and then now we're trying to develop it a little further, and so that hopefully we can show that it can work long term, and then we can hopefully get it to market at some point. So hearing is sort of primarily the way that we communicate. And Helen Keller, as you know, had a genetic condition where she lost her hearing and her vision. And when they asked her, which would you rather get back? She said, I would rather get my hearing back, because I can at least communicate with other people. And vision just gives me able to see things, but I can't communicate. And, humans, we're in our nature is we are, social, animals, if you may. So we like to communicate with others. And if we don't socialize, that's what causes cognitive dysfunction, of course. And really, balance is that sort of sense that everyone takes for granted until you lose it. But it's what gives us the mobility to be able to go places and do things. So our goal eventually is to actually have an ear institute at UCI in Orange County that would provide sort of the highest level of care and to find new solutions for these problems and sort of expand our research and train the next generation. And so that's our sort of eventual goal at UCI. And then, of course, this is my research team, so it takes a big team to do these big projects that we're working on, the regeneration of the cells and the development of devices for tinnitus and all the other stuff. We have software engineers, we have electrical engineers, mechanical engineers on a lot of these projects. So I wanted to acknowledge them, and that's all I have. I'll be happy to answer any questions you may have. Yes, we're going to, I just saw that one first, even though I know you did at the same time.
Where is the first question?
Right over there.
Oh, okay, I'll head over here.
I just wanted to know, I can go for that, no problem, thank you. Thank you so much for the presentation. I know you talked a lot about hearing loss. I have singular deafness in my right side. Some of the research that you're doing right now, I've talked to Hear Institute in downtown LA, and the only suggestion they all keep telling me is to get a cochlear implant to restore my hearing, because it's singular and I can't really detect speech. But are you guys working towards something where a cochlear implant will not be needed for someone that is singular deafness?
Yeah, so that's what that regeneration of those cells, the hair cell regeneration. Now that's going to take some time. It's not, it's still in the animal stage currently. So, and there is a limited time window. If you've lost your hearing in one ear only, then you have about 10 years that you could get the implant, because beyond that you lose too many nerve cells for it to be good enough for it to be able to compete with your good ear. Now, if somebody has lost hearing in both ears, then they can get the implant 15 to 20 years later. That's okay. But if you've lost hearing entirely in one ear, because if you get an implant, the implant's never as good as normal hearing is. And so people tend to be more likely that they wouldn't use the implant after a while, because they're like, oh, this sound quality is just not as good, and so they take it off. And so you've gone through this whole process for nothing. Of course I can't address your situation, in detail, but in general, there's a limited time window to get that. You have to, by sort of FDA guidelines, you have to try what's called a cross hearing aid first, which is a hearing aid that takes the sound from the deaf side and sends it to the good side for at least 6 weeks before you would proceed to potentially get the implant.
Next.
Or, let's just, because of the speaker, let's move this way. So we'll start on this side and we'll sort of move that way.
Make sure that they speak into the microphone, because it goes.
Oh, because it gets recorded, yes.
Do you have any estimate how much does it cost
For
the implant that you showed us?
For the ringing in the ears? Mm-hmm. The implant for ringing, it's not on the market. It's just still it's still, the implant is being built currently for our, studies. But, I don't know what the price would be. I mean, it would have to get to a commercial stage for the pricing to be determined.
I see.
But, cochlear implants, which are the devices that restore hearing, the implanted portion costs about $20,000. The outside portion costs about $10,000.
$10,000, okay. Thank you.
Sure.
Thank
Thank you. You were talking about the kids these days and how. Oh yeah, you were talking about the kids these days and how much they listen to loud music. I was wondering if there's a particular headphones that are better than others that we could suggest other than reducing the sound level.
Yeah, there are some headphones that are limited in volume, and so there are some that don't go beyond 85 decibels. So if I don't know of a name in particular to be able to give you, but what I would recommend is, the iPhones at least keep track of the loudness of sound that people are listening to. So you can actually look that up on your kids' phones to see how loud they're turning it up. And then you can have a conversation, say, hey, your music's too loud. Generally we wanted, and what our recommendation is, if you're going to listen to music for a while, is the volume level to be 50% or lower on the sort of the little volume thing, and then to take breaks, because it gives the hearing cells a chance to recover a little bit. Because the longer you go in a row listening to loud music, the more likely they are to get damaged because of those little mitochondria we're talking about.
Doctor, do you have any recommendations relative to after you've been swimming or showering in terms of the drops or Q-tips or that type of thing?
Sure. So Q-tips in general are not good to be used in the ear. In fact, when Q-tips originally got approved for human use by the FDA, it was a requirement that they have to say that not to be used in the ear. And of course, that's the only thing people use it for. And if you actually look at a box of Q-tips, it will say that on there, not to be used in the ear. So the problem with Q-tips is, number one, is they tend to push the wax further in. So they don't actually, like, a little bit might stick to it and you pull it out and you're all excited. But the reality is you probably pushed more of it in than you actually took out. The other is that the Q-tips tend to remove the natural oils in the canal that are protective for the canal skin. So by using Q-tips, you're actually more likely to get an ear canal infection. And by removing those oils, your ears become more itchy, and so then you end up having to use them more and more, and then that ends up causing more itchiness over time. What about alcohol? In general, you don't actually need to do anything for your earwax for most people because the earwax naturally migrates outward. So it starts at the eardrum, the skin, the outer lining of the eardrum, and then the ear canal skin continually moves out until it gets all the way to the outside. Now that system is much faster in a newborn than it is when you're older. But it still works. The more stuff you put in there, the more likely stuff is to accumulate. So, but if somebody's a hearing aid user, then it's more likely that they will accumulate wax, and then it would have to be manually removed. If someone is going to use something, we generally recommend a mixture of alcohol and vinegar, because one of the functions of wax is that it creates an acidic environment to kill bacteria. So alcohol and vinegar, and you use a little bulb thing or a little syringe, very slowly flushing it in there to kind of clean it out, assuming somebody doesn't have a history of holes in their eardrum or surgery on their ear or something like that. Yes.
Talking about earwax, I make too much earwax in my ears. And I come to UCI, your office, and they come and clean my earwax every 6 months. But my question is, if you don't remove the wax, does it make the hearing any worse, or does it cause some problems, or long-term problems, or short-term problems?
Yeah, not long-term problems. So earwax, once it gets to a point where it completely occludes your ear, then it can cause a significant drop in your hearing. But it's reversible. Once it's cleaned out, you can hear. It's kind of like having an earplug in there. So it doesn't cause any long-term damage in any way. It's really more of a short-term issue. If somebody makes wax at a faster rate than the body's able to clear it out, then they tend to accumulate. And so that can happen for sure in some people. But the other thing you can do is sort of a once-a-week basis is to kind of flush your ear with that alcohol vinegar mixture, which tends half and half is good, yeah.
Oh, here, let me get to you.
Here, while you're getting there, I think you had a question.
Yeah, the high-end hearing aids tend to have generational jumps, maybe every year and a half. But when you talk to candid audiologists, most of them say that the perceptible improvements are not huge. So my question is there anything looming on the technological front that will produce a really substantial improvement with the high-end devices?
So as I understand, hopefully I understand it correctly, that so from a year to year, obviously hearing aid companies, just like car companies, are making new hearing aids every year. And the sort of relative change in technology from one year to the next is not substantial. But probably every 5 to 7 years, there's enough of an improvement, and so that there would be a noticeable improvement by the patient. And most of what actually improves in hearing aids is really how well they do in a noisy environment. But to answer your question in terms of is there a sort of next level technology, that next level is what we're working on, is sort of that the devices that directly vibrate the eardrum, which produce a much wider pitch range, because they can produce essentially what the human range of hearing would be. And that's why they sound a lot better than...
That's 10 years away.
Well, these things, they just need money, but to accelerate them. So yeah, if we have no money, yes, it might take 10 years, but if we have the money, yes, much faster.
A lot of this audience may not have that kind of horizon left.
Hopefully. Oh, hang on. I think someone has a microphone there.
Oh, Hi, I have 3 questions. One, are you familiar, if I'm saying it right, with misphonia? And 2, people with autism, they are affected more by sounds, I believe. And 3, you talked about balance and feet. Are you doing any studies on neuropathy for that?
Okay, so the first question was misophonia. Misophonia is a condition where people have like an emotional reaction to certain sounds, like sounds, like think about sort of if you're the nails on the chalkboard, you kind of have that, but they have it with common sounds, like if somebody's chewing or I don't know, like someone's clearing their throat or something like that. That will then set them off, and they have to sort of really get sort of upset and stressed out. There is a lot of new research in that area. It's primarily a brain-driven condition. It's not an ear-related issue. Someone's very popular, getting a lot of texts. There are some new treatments available medication-wise. So it's really a medication and what we call cognitive behavioral therapy that's sort of beneficial for that. Your second question was about autism. Autism and sound sensitivity is also, again, driven by the brain. That, again, is this condition related to the brain sensitivity and how it sort of prioritizes information. And so we have some new treatments that we actually have worked on that we want to at some point do a clinical trial in an autistic group of patients. They're, of course, much more challenging a group to do experiments on because we have to get feedback and whatnot, and we have to find a particular group that we can get that information from. And then your last question, neuropathy. Yeah, neuropathy. We actually developed an insole for shoes that could actually detect pressure and can then provide feedback using vibration, so that basically, because the problem with people with neuropathy is, I could be leaning on my right foot. My brain knows that more pressure is going there, so it contracts the muscles on this side to pull me this way so I don't fall over. But in neuropathy, the brain's not getting that information, so it doesn't know. So we developed this insole that could actually detect pressure, and then we had little things that were like in form of a belt that then would vibrate like around the chest. So then people would know that they're actually tilting too far. We also made one that actually went inside a hat, so you could wear like a cap and it had the little vibrator. So then you're leaning too much, and then it would sort of vibrate. So then it would sort of make you sort of correct yourself. It never reached market, but that's we have done work in that area. If you were to do what, I'm sorry? Oh, misophonia. Right now, I don't, right off the top of my head, I don't know if there's anyone who's treating misophonia. Usually, we would have to see usually like a psychologist for the cognitive behavioral therapy, but it has to be someone who's familiar with the condition. So sometimes they have to be kind of preempted with some information so they know what it is before they start working with the patient.
Hearing loss caused by meningitis, is there anything they can do about that?
Meningitis, the problem with meningitis is Meningitis, when meningitis occurs, you have a lot of inflammatory cells around the brain. And there is a channel that goes between the inner ear and the brain fluids. And so the bacteria can go through that channel into the inner ear. Once they get into there, it causes a significant amount of damage to the inner ear. And then the inner ear tries to repair itself. And because the inner ear is bony on the inside, it ends up creating new bone in that repair process. It first forms like scar, and then it fills with bone. Now, if we could catch people early, then we actually put that cochlear implant in very early before the bone forms. But if it's, someone's had it and the bone's already formed, we could still do the implant, but we've not found the implant to work as well as it would otherwise. So, but if somebody just gets some high-pitch hearing loss, then right now the only solution would be like hearing aids.
Thank you.
I have two questions. One, we were talking about mitochondrial rejuvenation. Is anybody in the world trying embryonic stem cell research on that?
So yeah, stem cell work is being done for hearing. The challenge is getting cells into the inner ear and to get them to get to the right place. So there's more work on trying to regenerate the cells that are there and turn them into hair cells. Because birds are actually able to regenerate their hearing cells. So, if a bird goes to a concert with you, you'll both walk out with hearing loss. But the bird in 3 weeks will have their hearing back. And so based on information gathered on research in birds, a lot of the mechanisms have been worked out in terms of what the sort of steps are for the cells that are underneath the hearing cells to turn into actual hearing cells.
So who's doing the research? Where?
Who's doing research on what? Hair cell regeneration?
Stem cell, yeah, embryonic
Stem cell, actually, I know that there was somebody at University of Illinois in Chicago who was working on it, but he's been working on it for 20 years and hasn't really yielded much.
In China or Korea?
China or Korea, not that I know of, at least. There may be, and I just am not aware of it, honestly.
Yeah. The second question is...
I'm sure if you look it up, you can find it.
Okay. Can you restore the deafness secondary to streptomycin or drug-related injury to the nerves?
Right now, it's primarily with devices, but in the future, we will have ways to do that. And one of the reasons actually streptomycin causes hearing loss is because of a dysfunction in that mitochondria. So we're actually doing experiments on another drug in the streptomycin class to see if we can prevent the loss of hearing by using the mitochondria.
We're going to have just 2 more questions here.
I was just wondering about vertigo and imbalance. Is that an age-related issue, or what causes that?
So, and I should sort of separate probably imbalance from vertigo a little bit. Imbalance does occur more as we age, partly because neuropathy is more common as we age. It's still an uncommon problem, but it's, you're more likely to have neuropathy at age 80 versus at age 30. And it's primarily related to the gradual destruction of nerves, which is from high blood sugar and sometimes drugs and things like that. So imbalance is definitely more likely as we age, and because our brain's ability to coordinate balance is not as sort of sharp as it is when we're like 20, and also our muscle strength drops significantly as we age. So there's multiple factors that go into balance. Vertigo, however, can occur at any age. It can occur when you're 10, and it can occur when you're 80. There are different causes. Vertigo in like the younger population, and in general, younger is anyone younger than me, and older is everyone older than me. But and that changes every year. No, but in sort of let's say it's people in their 20s and 30s, and a vertigo is almost universally caused by migraine in the younger population. In the older population, it's partly migraine and partly due to these little crystals in the inner ear that can come loose and float inside the fluids, but not necessarily age-related.
That's what I wanted to ask you about. I had that kind of vertigo some years ago, and now someone else I know is having it. So where do those little crystals come from, and how many are there? And are there only supposed to be that many? And I mean, how does that vertigo, you know, I mean, there are certain movements that you have to do to get rid of it, and so on and so forth.
There are tens of thousands of those crystals, so it's, you know, and we keep making new ones and stuff. So, but the problem is those crystals are embedded in this gelatinous material in the inner ear balance organ. And but what actually causes the crystals to break off is thought to be due to a change in the fluid pressure in the inner ear, which occurs as a result of a blood flow change to the inner ear. That blood flow change occurs usually from an attack of this process related to migraine. So there are some people who have migraine who never get a headache in their entire life and will only get vertigo as the only manifestation of their migraine. So that most commonly is what triggers it. But then the migraine may go away, just like a headache goes away, but then the effect will stay because those crystals are now broken and are in the fluids of the inner ear, so they're floating around. So every time you move your head in a certain position, you'll get the vertigo. And then you just do the maneuver to get them out of that wrong part of the inner ear, and then usually it goes away after that.
Oh.
I think there was somebody who had a question there.
Oh, you want one more? Here,
So the question, I'll repeat the question. So the question was, is there any correlation between sudden sensory neural hearing loss and vaccines? So sudden hearing loss is when most commonly there's a disruption to the blood flow to the inner ear, and that causes you to suddenly drop your hearing in one ear, and then some people can go completely deaf from it. Now, if we get to it very early, we can actually a lot of times reverse it. But if we don't catch it early, then it can become permanent. Vaccines will not directly cause this problem. A lot of things that are attributed to vaccines or COVID are sort of sometimes maybe overestimated because a lot of patients who sometimes think that something is due to the vaccine, when I ask them, like, well, when did you get the vaccine? They say, well, it was like 6 months before, it was a year before. Well, that vaccine is long gone out of your system. I mean, that vaccine's immune effect for the COVID vaccine only lasts about 6 months. So the chance that you would get a hearing loss 6 months after the vaccine is near zero. If you're going to get a symptom from a vaccine, it's going to be within the first couple of days. It's going to be within 72 hours generally. Now, that effect has to do with the fact that vaccines are intended to create an inflammatory response in your body. That's the whole idea of the vaccine, is to create an immune response. That immune response can be detected by the brain. That brain then reacts to that. That then can start this cascade of processes which can then lead to a drop in hearing. And that process is also related to that migraine that can cause vertigo in some people. That sort of atypical form of migraine can cause sudden hearing loss in some people. And so we found actually in some of our research is when we treat people with this sudden hearing loss with the migraine medications, in addition to the traditional treatments that they get, which is steroid pills and injections in the ear, we could get much better results in terms of hearing, and we could get people less likely to need hearing aids or an implant. But can the vaccine directly cause it? The likelihood is quite low. Based on a lot of the studies have been done when they looked at the incidence of sudden hearing loss before and after the COVID vaccine, which is sort of more the emphasis nowadays, partly because it was a vaccine that suddenly 100 million people got in a very short time span, which has never been done in sort of the history of the United States. So. But then, it does create an inflammatory response, but then there's a lot of after effects that people tend to pin on the vaccine that are really not from the vaccine.
All right, let's thank Dr. Djalilian. He will be up here after to take your questions, and our next meeting is October 13th, and Dr. Dang will be here, and he will be talking to us about finding comfort in long-term cancer care. So please come join us.